just as a brief overview, I'm going to put, just going to re-emphasize some of the classifications and definitions of what we consider cervical deformity, so that I can then explain kind of my approach and where, in what cases would be appropriate for a cervical corpectomy. Briefly touch on the complications, other alternative treatment options, and then discuss some of my techniques in detail, and then go through some case examples. So, as a review, there's several classification systems for cervical deformity. The most accepted ones is the AIM ISSG criteria, which is an apex location-based classification. As you can see, the deformity descriptors on the left. Primarily, we're going to be talking about the cervical and cervical thoracic deformities, with then very extensive modifiers. There's also some alternative classifications that came afterwards. The European CSRS classification is a little bit more simple in that it looks at cervical balance. The spine is either imbalanced or balanced, and then within those contexts, you either have regional kyphosis or lordosis. And so, these four categories are just maybe a little bit more simple way to communicate deformity. And then more recently, ISSG, led by Hanjo Kim, published on this extension-based classification where they talked about three different groups. Flat neck, there's your term, Dr. Hart, that was in their publication, focal kyphosis, and then the CT deformity. Flat neck really implying that there's flexibility between neutral alignment and then extension, and focal kyphosis, which is a more stiff focal, kyphotic deformity, and then cervical thoracic deformity is characterized by a very high T1 slope. And, also, those are obviously radiographic classifications, and then we've been talking all day about the modified JOA index, but there's several indexes that are used to assess patient-reported outcomes. The MJOA particularly helps us quantify and has been well validated for myelopathy, and so this is a critical survey to be capturing in this patient population. And at Iowa, we've incorporated all these into the medical record by Epic, and so we automatically collect MJOA and NDI on cervical patients. And obviously you guys can read some of the details of what the score entails, but it's more or less upper and lower extremity motor function, sensation, and micturition. And what's nice is that this is more or less an internationally validated way that we can give descriptors such as mild, moderate, and severe, and then compare patients with myelopathy, because many of the patients with cervical deformity have myelopathy, and that has its own kind of role in treatment. As talked about earlier by Dr. Trinellis and others, there's several tools we have for deformity correction. Dr. Ames and the ISSG have 8 years ago defined these different grades of osteotomies that Dr. Trinellis went through earlier. And for purposes of what I'll be discussing, we're going to be focusing on the anterior osteotomies, mainly the corpectomy type 3s. And I think it's important for us just to take a step back and look at one of the most experienced cervical surgeries in the world. And the performing osteotomies is riddled with complications, but it does allow you to achieve relatively strong and angular corrections. But you can see from these OR times, from Dan Rue's series, these OR times and blood losses are not insubstantial. And so for a surgeon that isn't doing these every week, you can imagine how these complications and the danger goes up with these. And I'll show some cases where with the corpectomy and some additional techniques, we're able to achieve in the right patient some of these angular corrections almost equivalent to PSO. Likewise, this is Chris Ames's 95 consecutive series of his own patient, and you can just look at the startling complication rate in the 30s and 40s for 3-column and even SPO osteotomies. New neurologic deficits, although most of them are transient, 20%, 13%. These are substantial complications. And then common complications with any anterior approach that we're all familiar with are listed here: dysphagia through arthrosis, vocal cord issues, vertebral artery injury, and then, in general with deformity. And we know the mortality rates at 1 year for cervical deformity can exceed 9%. And so, my experience as a younger deformity surgeon practicing in the state of Iowa at a tertiary center where I'm the end of the line for many, many patients, and I don't have a senior partner that does adult deformity, and so to some extent I'm on my own. And goals when starting practice 5-6 years ago were really to build a reasonable reputation and minimize complications. And I'm hyper-focused on what the actual drivers of disability are in all my patients. So they have radiculopathy, myeloradiculopathy, neck pain from deformity. Because I have a lot of patients that, and this is one that I saw a couple months ago as an example, a 44-year-old gentleman that came in with neck pain, no myelopathy, normal function, neck pain. And so you look at this case, you're like, well, are we going to do some crazy VCRs on him and give him myelopathy or paralysis? For a low level of neck pain, this is something that we're not going to operate on, or at least I'm not. And that was a consensus I had from a few people I showed around the country. But I think it's critical, especially as a young surgeon, to maximize your outcomes with minimizing your complications, and that's kind of been my strategy over the last several years. And so when looking at the indications for corpectomy, I know this came up earlier, what type of cases are appropriate? And it's really going to be this focal cervical kyphosis. These group 3s or people with extremely high T1 slopes or cervical thoracic deformities are not obviously going to be necessarily appropriate candidates for corpectomy. And there's going to be a lot of cases of compressive myelopathy, and I know Dr. Hart mentioned that earlier. And then several of these cases have had destructive lesions from infection, tumor, chronic fracture, necrotic bone, or similar. And so in the cervical spine, my experience for the last 5 years is I put in over 80 of these expandable cages, happen to use all of the Globus type. And, in my series, roughly, 25% have been for deformity, 30% have been for degenerative CSM, and, the rest for trauma and tumors. But I've never had to kind of take out a cage or revise a cage. I've had a few kind of standard complications, but I want to emphasize for cases of quote-unquote cervical deformity, I'm backing up these cases 100% of the time with posterior instrumentation and sometimes some additional work. And I always will use it came up earlier. I always will use variable screws because if I'm going posterior, I'll always use variable screws because I want some of that ability to fine-tune that correction or get some additional correction, and a fixed angle screw would not allow that. And so I'd argue if you're going to do posterior instrumentation, there's no reason to use fixed screws because you're going to get your fixation, your definitive fixation posteriorly. And although this is not applied to, this is not a deformity series, when comparing ACDFs to corpectomies, in the short term, there were some benefits to ACDF, but overall, the important outcomes, such as fusion rates and functional outcomes, were the same. And so, you're not necessarily going to do the corpectomy unless it's warranted, but more or less equivalent outcomes is how I see it. And the historic studies on long corpectomies using allograft are not great above 2 or 3 level corpectomies, with failure rates in non-unions up to 50%. Expandable corpectomy cages have a much better but very heterogeneous, systemic review of their success. But I think when used properly, they can be extremely useful. And there are some limitations, of course, such as cost and grafting around them that is possible to overcome. And so I'll jump into a case example. This is, we skipped a 65-year-old female that, and many of these patients present more or less acutely with some neurologic deterioration, at least at Iowa. And so I've got to make some relatively quick decisions of what to do. And she had neck pain and bilateral upper extremity burning without any falls, history of posterior surgery done decades ago by neurosurgery, some weakness, but she's got myelopathy and clear focal deformity here, with a markedly positive SVA and cervical kyphosis measuring over 50 degrees, but relatively preserved or normal T1 slope. So I think there'd be a lot of different opinions on how to treat this. And you can see, I haven't measured up, but some flexibility to this when she's laying supine, but cleared cord compression and probably chronic myelomalacia and damages. And hard to fully understand what's going on with the posterior elements, but there's some erosion, not complete, not total fusion of the lateral mass. I tend to get CT angiograms for all cervical deformity cases just to assess for aberrancies and surgical planning. And so I ended up doing this in a staged fashion. There's such a delay in this laptop versus. So I did a 3-level corpectomy with cage placement, and really, I often will use Gardner-Wells tongs, but in this case, I used the halo so I would have some more rotational control, and just later supine on the bed and just worked combination of weights, direct me pushing down on the head, pushing on the halo, and then expanding this corpectomy cage, being very careful not to violate these end plates to achieve this slow reduction, and then. Just because of our resources, I tend to stage these procedures a few days or a few weeks if possible, and she went into a halo in between, and then I backed it up posteriorly, and she had a lot of erosion of some of her posterior elements, and but that this is, I didn't do any osteotomies in this case, and no major posterior decompression. It was probably 2 hours for the front and about 2.5 hours or 2 hours for the posterior aspect, and so. Is this some technique? And this is not the same patient, but this is the type of fusion that I'll get. In the corpectomy cage, we're putting, ground up autograft if it's not from an infection or tumor, and then I'm using DBM, other DBM matrices to put inside the expanded cage as well as laterally to it, and that's where I think we're getting some of the that lateral fusion. And so, as discussed previously, it's critical to get appropriate workup with full-length radiographs if it's available, MRI, CT angio, bone health workup, and how I'm able to achieve a lot of this reduction is all about how I get the patient set up on the table, how I use traction, how I use some leverage, and then intraoperatively. I do use Caspar pins, I use Cobbs, and I have this really nice disc distractor similar to what was demonstrated earlier, but I think it's like an arthroplasty mimic from Mobi-C that we built. Globus had a custom instrument. It gives me a ton of leverage to really crack open the anterior column and distract. But I'm meticulous about my neuromonitoring so I can do some of these things safely. Just some pictures from, not necessarily this case, but just a typical placement of this corpectomy cage. And so, obviously, when we're evaluating these patients, you're going to look at all these different factors to assess kind of your approach. Obviously, if it's not going to be an appropriate candidate for corpectomy, I'm not going to do a corpectomy. And it's not necessarily my default approach. Otherwise, I'll show you a case of kind of more or less ACDFs that were done and kind of wedged to wedge a deformity open. But it's again critical to understand the goals of surgery, and it can't always be formulaic, and that's some of my suspicion with these software programs where you plug in someone with cervical deformity. It tells you you need this lordotic graft, you need this series of Smith-Peterson osteotomies or this PSO, because you can achieve some of these things, or you can achieve a good outcome, maybe not with achieving a perfect radiographic outcome, and depending on what the patient's dominant issue is, whether it's myelopathy or radiculopathy. And so I think it's always really important to take a step back and be like, what are we trying to treat here? How can I make this patient better with the least invasive procedure? And this is a kind of an old study that talked about when you're going to be able to get float back from the cord, when anterior work is appropriate, this concept of the K-line, and so just something that we don't hear talked about much anymore. But this is more of a cervical myelopathy concept rather than a deformity concept. But still, a lot of what we do in deformity is decompressing the cord. And so here's another case. This gentleman presented with bilateral arm weakness after having several carpal tunnel surgeries that failed to improve, and he was frankly myelopathic as well. Similar, we have a focal deformity, not quite as much cervical kyphosis, the relatively normal T1 slope. Workup reveals severe cervical spondylotic myelopathy with focal kyphosis. I was going to initially treat this with I actually approached the case trying to treat this with ACDFs, but his bone was so hard and I was having difficulty getting behind the vertebral body, so then converted to multi-level corpectomy during the case. to get adequate decompression and then expand the cage to really achieve that, that reduction. And, he had dramatic improvement of his myelopathic symptoms and was very satisfied with the surgery. And you can see just even in short-term follow-up, some improvement of his outcome scores. And here's, another case did more recently it's a little bit more unique, and I didn't necessarily go for, the largest surgery that we could have done. 68-year-old female with severe progressive neck pain, deformity, inability to maintain horizontal gait, but quite unhealthy. Diagnoses of cervical deformity, and cervical myelopathy. And you can see here marked positive SVA, coronal deformity, and her T1 slope actually wasn't too bad, but osteoporotic certainly. And these cases, obviously with this severe coronal deformity, pose a little bit more of a challenge. As you can see here from a couple of the sagittal slices on the CT, there's not much posterior element-wise to fix into. And so, I started this considering, and, I'll discuss, I ended up doing, come back to this picture, but I ended up doing a staged procedure. I don't have my halo pictures, but I started with, more or less these ACDFs, but that bottom was almost like an osteotomy where I really broke up and wedged something in there, and I provisionally put her in a halo, and then put her, when we were doing the posterior surgery a few days later, and this lady was very claustrophobic. She liked it. I was going to leave her in a halo given her bone quality and the lack of fixation posteriorly, but she was adamant against it. And I think if you really look at this picture, you can see, this is not just positioning her head and letting it sit here, but there's a tremendous vector of force that I'm pushing posteriorly, and then we're pulling from the back of that halo. So we're essentially generating this vector where it's pulling her head up and out and straight. And I can adjust the height of these pads and those halo pins to really shove her head back into extension and then pull it into flexion with the weights and how I have this halo set up. And so before we were starting the case, I'm getting my alignment where I want it to be, and then more or less dropping hardware, not having to do big osteotomies. I always made fun of these little shims, but I finally ended up taking a lot out and fused over them. But when I distracted her in the coronal plane, and she had huge holes in her facets, and I tried putting bone graft in there, but they had these things, and I filled them with DBM and put them in the facets, and just thinking it might give her a little bit more support. And so she's done reasonably well, and I ended up taking off the halo because she just couldn't tolerate it almost immediately post-op, and she hasn't collapsed, and it's been 6 months. And I just want to close with a reflection that there's obviously a role for certain procedures, and I've loved the power of these expandable corpectomy cages, and I've had a lot of these focal kyphotic cases, whether they're degenerative, whether they're infections or tumors, where I've been able to get tremendous correction just from using halos and the expandable corpectomy cages. But there's certainly cases where, especially at the cervical thoracic junction, or incidences of high T1 slope, where that's just not an appropriate treatment, and all the other osteotomy treatments or posterior-based treatments are appropriate. And this is probably one of my most intense cases. 57-year-old gentleman with liver failure that had a previous, I think it was like a C3 to T1 or T2 fusion that for a fracture that was infected, and he was up at a VA that was getting multiple INDs, and he basically presented to us with a halo that was loose, and he had draining fungal wounds from the back of his neck, and you couldn't even see his posterior neck wound because the halo vest was basically at the back of his skull, and he had remnant hardware everywhere. This guy's got liver failure, and they're not going to replace his liver or transplant his liver because he's infected. And so he was like totally screwed. And you can see, and he's can't walk anymore, fully myelopathic, but still has function. But you can just see this. This deformity is unbelievable. You can't access it from the front. And look at his skin. He's got a draining fungal wound, and doing a massive 2-level VCR, is that a reasonable approach? And so Just to tie in Bob's multi-rod talk, what I ended up doing is putting him in that same halo kind of setup, which I showed before, where we're driving his head into extension and then pulling it in traction. I'm essentially pulling his head out of his chest with this. And I think I put the halo on. I put as many pins in that thing as I could just to grip his skull with whatever he had, and laid him down. I was actually able to pull his head out, and then did a dual rod construct, did occiput fixation, and his bone was just, it was you couldn't even see. They'd been operated on IND so many times that, the difference between the spinal cord and the scar, and so there was a lot of areas that weren't even instrumentable, but I went down to T6 or so, or this is even T8, I believe, and then and did dual rods with dual maximal fixation into C2, as you can see. I filled every little crevice I could with screws, and the guy I was able to get him out of the halo immediately, and he was extremely happy. Didn't have much neurologic recovery. He was like 3. He's never was able to walk again. But and then they ended up putting a flap over this to finally get it to heal. But it was quite a crazy case, and obviously different techniques But I still was able to avoid a 3-column osteotomy just by using some other techniques. So in conclusion, global preoperative evaluation is critical. The goals of cervical kyphosis correction are really restoration of horizontal gaze, decompression of the spinal cord, spine stabilization, and your surgical options are really vast, but the anterior corpectomy for focal disease is quite powerful. But I always, would back it up with posterior options. You obviously have, the possibility of osteotomies, but these cases are certainly challenging and often controversial. Thanks.
These are great cases again. So we've talked about this sort of all day long. What do you use for biologics in that expandable cage?
So I'll take, again, if the bone from the corpectomy is not infected or tumor, I'll pack, that cage with a local autograft and then demineralized bone matrix in syringe format. Mm-hmm. And then I really fill the I'll put some Surgiflow down right on the sides, so that's on the spinal cord. And then on top of that, I'll squirt in DBM all along the side of that cage, mm-hmm. And just fill that whole cavity and then put the plate on. And then even if the plate's got a window, then I'll put more graft down and really, I'll try not to pressurize it too much into the spinal cord, but just fill that whole area with DBM.
So DBM, and you're really putting it more outside the cage than in it?
Well, I'm filling
both?
As much as I can inside.
Both. Yeah,
but
both.
Obviously there's limitations to the windows sometimes, and you can't. But yeah, there's.
Right.
I fill every area I can.
Both, right. And you say you're not doing you're really not doing 3-column osteotomy, but it sounds like what you're doing is loosening things in back and then really using traction or in some form positioning and close reduction, really.
I do osteotomies.
Yeah, I know you do.
But
the cases you showed.
Yes, but that's kind of my point, is that you can achieve some pretty significant reduction without burring off the facets, mm-hmm. and leaving as much posterior bone for fusion.
Right.
And then risking, just risking. I've done several T3, T2 osteotomies, and I've had some delayed deficits and having to go back, and I still distinctly remember flying in the middle of the night back from somewhere because I was the only one in the hospital that could take care of it to release the epidural hematoma, and then do more in the middle of the night. It's just like. We have a new partner coming that can help me with some of those things possibly.
I'm glad you're not going to be a man alone much longer. So, again, it's so I'm reminded of a comment that Stu Weinstein made when I was a resident, and I'm sure he won't mind me quoting him, but he had trained there, and really at a time when nobody was doing scoliosis surgery, or very few scoliosis surgeries, and then he became who he is, doing cases, all kinds of cases all the time, became an excellent scoliosis surgeon. And I asked him once, well, how did you learn to do this? And he said, I just dug in. And I think that's kind of the situation to some extent, we're all faced with, but certainly when you're in a practice alone, you have to rely on your own experience and your own judgment. And so, the last thing I'll say is I tell our residents, and our fellows, are not residents anymore, but our fellows, I think the most important thing to learn in training is how to think for yourself, because you're going to have to do that over and over again. And I don't know if any of them are still here. Did you guys hear that? Okay, good, good.
Yeah, absolutely. I mean, don't be afraid to be creative within reason. It's the same thing, like I started doing these all as one-stage procedures, but just the logistics of my hospital system, and I found I could, I was less tired if I broke them up, and I could safely stage many of these anterior posteriors within a day or two, sometimes even weeks, running my residents into the middle of the night. I mean, there's things that just weren't feasible in the add-ons, because these cases can, if you do it all at once, can be 6+ hours. And so, it's an example of just something that was a little bit different than what I, had trained on.
Right. Well, and that's yet another thing I found to be true early in my training, in my practice, was I thought I was doing things exactly as my mentors had done them, with me. Thought I was, but I'd find in some cases they didn't work, or they failed. A multi-level corpectomy was a classic one. So I watched Henry Bullman do I don't know how many of those as a fellow. No plates, no halo, and those were autografts, and they seemed to all heal. I had grafts kicking, regularly in the first few I did, and I had to figure out a different approach. So, I mean, it's and also I think different hospitals and different practices require different approaches. So that's what you're kind of identifying. It sounds to me as some of the ways that you were trained and what you saw done won't work in your setting, if I'm hearing you correctly. Yeah,
just like pre-op, another one, pre-op halo gravity traction. At Children's they'll do it, but it is a bear to try and do that on the floor. And so you adopt ways to do these things that might benefit from a few days of traction on the floor, because there's no one that knows how to do it, no nurses that can deal with it, just to figure out how to do it in the OR, right away.
Those were awesome cases. Thank you for that. Couple questions from a new fellow. Is that halo traction technique that you use described? Do you have a publication on that or a reference we can?
So I learned, in part they did, I think Dr. Lanke did that at times for some PJK cases, and then I kind of expanded and but it's not, I can send you some pictures from my cases, but it's not really written up. And you've got to be, it's just, you got to be careful, because you don't want to rip the thing out, and how much can you tolerate. So when you're flipping this patient over, I mean, even how I put the bed, I use the OSI table. I don't know if you guys have those here. I mean, there's different types now. The Trios, which is an automated one that you can lock and unlock, or the pin-based ones. And so you've really got to think about where you're going to line everything up before you flip a patient, where those halo pins are, and how you pad things up. And otherwise, you're going to have a spinal cord injury just when you flip. And so it's it's kind of a graduated thing that I started doing more of, that I really had to pay attention to.
And then from doing that, does that imply that these deformities are rigid or flexible? Do you know that pre-op with flexion extension?
Yeah, I mean, you can even see from some of those. I mean, I didn't include a lot of extension films. We get them all.
Okay.
But most of them are rigid. But with enough force in the head, unless something is truly fused, these very stiff, deformities can be pulled straighter. And I mean, I think that the first case I showed you is a good example of it.
And so are you able to achieve that until you get like a monitoring change, or do you have a limit or you don't usually get those, or?
Yeah, so I'm hyper paranoid about monitoring, and like for those corpectomies, you've exposed the whole spinal cord, so you're staring at it, and so you're not really going to get often monitoring changes if you place things right. And it's not like the spine is super kyphotic at the time I'm placed, and I've already, let's say, distracted with capsular pins. I have a sense of the bone quality. I've been paid attention to my end plates. Did I violate any of these? Is this going to, the end plate's going to tolerate that? And then on fluoro, I'll be able to expand and add more weight, or kind of push up on the halo, or the pull on the Gardner Wells tongs through the drape. It's just kind of it's a hard thing. It's become more of an art than, it's something that's just real, step 1, 2, 3.
Do you ever use the bivector traction?
I do.
Wrote up.
Yeah, for posterior cervicals. But that again, if you have it, I find that tends to fuse people in a little bit more cervical thoracic kyphosis, as opposed to the halo, where you can kind kind of shuck the head back. You can't, I mean, you tend in the bivector, that head is a little bit lower than the shoulders. And so depending on what I'm doing, I'll often drop the bed. How it was described, in his papers is that he kept the top of the bed fairly high on the rungs, so the head was in quite a bit of flexion for exposure, decompression, and instrumentation, and then would bring it up to an extension. But even that, I found that it can. So I usually drop it lower so that I'm at a baseline. I'm not fusing too many necks in a little bit of thrust. But I would like to your point about occipital cervical fusion. I will use Gardner-Wells tongs for that, but I'm kind of hyper vigilant about the jawline and the face and positioning before I start that case. So I'm like looking at the drapes and everything. I usually don't move it much. Like that one, I'll just put in maybe fixed extension and then just fine tune it with the ropes, the weights, and the bed, where I'm happy radiographically and then visually before I scrub in. Because I just don't like halos, or I don't like Mayfields.
Yeah, I'm not a Mayfield fan. I use it infrequently.
For traction, actually, I prefer the pre-op awake traction before anesthesia. It can save a lot of effort. It can make surgery much easier. And also, we can know how much is a safe range of reduction. But 100% reduction under anesthesia may be sometimes risky, some high degree kyphosis. So sometimes the awake reduction, preoperative reduction, skeletal traction reduction is helpful.
Yeah, that's probably standard at institutions. I mean, certainly at WashU, that's what I learned, that was standard. We put people like this in traction, and yes, you have to be very, very careful, because obviously, it'd be devastating to get a deficit. I luckily have not had, one, and have very good monitoring, so.
Right. Sang, do you do that in their hospital bed or in the OR or both?
Oh yeah, in the hospital bed, yeah. So and the fixed deformity, the pre-op reduction is meaningless. So we have to reduce in the OR. But some rigid deformity is not reducible by extension views or some dynamic X-rays. So a lot of cases, especially for high cervical spine or CT junctional deformity, it's very helpful. Yeah, it can make surgery 50% easier, for example, less challenging.
Yeah. No, I totally agree with that as well. Awake traction, it's a very safe approach.
Well, so yeah, same concept for facet. We were just talking with the fellows about facet dislocations, bilateral facet dislocations. I mean, standard is to do that awake with traction and, monitor and, kind of similar concepts. So, all right, appreciate it.
All right, great. Thanks, Andrew.